Oh, I'm Maria Mogollon. I'm internal medicine doctor from Venezuela. And here in US, I'm an APRN. I've been working since I'm a provider with obesity and diabetes. I'm not an endocrinologist, just focusing on obesity and diabetes. I'm here representing, and it's an honor for me, representing American Association of Clinical Endocrinologists. I've been working with them as a faculty. I've been doing a lot of podcasts with them. If you can join us in our portal, you can see a lot of stuff with my name. And today we're going to talk about it's a topic that is more for clinicians, but since I know there's different attendance here from different areas of obesity, we're going to try to make it a little bit different. Okay, so everybody's in the same page. So today we're going to start talking about treating obesity from diagnosis and care management. So the reason why we are here, and I think everybody in this room agree with this, is about this number. And it's especially United States. This is the number worldwide, is the representation of obesity worldwide, 15%. And in United States, 42.4. But this is not the most important, it's the trend is what is important. 1999, the prevalence of obesity was 30.5%. And this is now, and what is projected to 2030 is 50%. So in 2030, out of 10 persons, half of them will have obesity. And this is why we're here today. We need to stop this number going higher. We need to treat it. We need to diagnose, but the most important is we need to prevent this from going higher. Multifactorial diseases, conditions that can play important game in the causing obesity. I will be happy to add here the allergenic food as a cause, but it is true. There's people that are more predisposed genetically to have obesity than others. There is a true when somebody sits in the office with you and asks, no, I have a genetic predisposition. It is 100% sure that is true. However, if that same patient with the predisposition of obesity is in an environment that is not obesogenic, not necessarily will develop obesity. And the opposite happens. Patients without the genetic predisposition in an obesogenic environment will develop obesity. So it's not cause and effect. We also have the environment, of course, we all know if we have an environment that is obesogenic, we're going to increase the chances of creating obesity, like in the United States. Developmental epigenetic is another good factor to take into consideration. Epigenetic is the way a gene is expressed depending on the environment that makes that gene express differently, or rather than changing the sequence of a DNA. This is not a changing of sequence. This is just an expression that can change depending on the environment. Physiology. So when we talk about physiology, when in terms of obesity, there's two pathways that we need to understand. The orexogenic, which is the ones that create hunger, and this anorexogenic pathway, which is the one that gives us satiety. Orexogenic, there's a main hormone that's called ghrelin that is increased when you have that hormone increase, you're more hungry. And the anorexogenic is when we hear all these hormones are so familiar with the new medications, GLP-1, GIP, leptin, and PYY. We're not gonna talk about in detail of that, but we have also hormones that you can create resistant or abnormality in these hormones that can also create difficult to lose some weight. So sometimes we need to know that a patient with obesity, and when it's in that stage already, could create some resistance to the anorexogenic hormones, and that patient can't lose weight because the pathway is abnormal. So it's not their fault that they're not losing weight. It's not because the patient is constantly eating because of their fault. Sometimes it's not their fault. It's just the same abnormality of the fat tissue that is creating that resistance. And of course, the behavior that we have been talking about since the beginning of this Congress, more screen time, more TV, more smartphones, etc. So what is ACE proposing? What is the evaluation when we are in front of a patient with obesity? This first thing is to do the diagnosis, right? So we diagnose the patient based on the gold standards, the BMI. BMI above 25 is overweight, above 30 is obesity, and obesity has 3 categories, 1, 2, and 3. But category 1 is above 30, category 3 is above 35, and in category 3 is above 40. So once we categorize a patient, okay, you have a BMI in 30, but not all the patients with a BMI in 30 are obese. So we need to also measure other anthropometric information like waist circumference. Waist circumference, very easy, just measure it around the waist in the upper anterior iliac crest, and you measure the circumference, and if it's above 40 in male or 102 centimeters, 40 inches or above 102 in males, that's abnormal, and the chances that the patient is obese. And in female is 35 or more than 88 centimeters. So when we have these two combinations, we also can do some fat percentage, body, the composition, the body composition, but it's a little bit more trickier. We need to have DEXA scan, which is the gold standard to measure the body fat. It's not easy to do. I'm not saying you can't do it. If you have the capability, financial capability to do it, that's fine. But the most easiest way is measuring BMI and, of course, the waist circumference. Once we understand the patient is obese, then we go to complications. It's not the number on the scale. It's not about BMI. It's not about waist circumference. It's about this. It's about the complications that abnormal fat storage is causing that patient. And that's what we need to focus on. Not only on the BMI, not only on the scale like Dr. Holmes was mentioning. It's not, you can have a BMI above 30, but that person doesn't have complications. So what ACE is suggesting is to create this model and staging our patients. So if we have, and this is above 20, BMI above 25. If you have a patient with a BMI above 25, but with no complications, then we can just focus on lifestyle. The treatment for this patient, the focus on this patient will be basically lifestyle modifications. If the patient has a BMI above 25 with some mild complication, mild to moderate complications, then we can start talking about adding some anti-obesity medications. And with the patient with a BMI more than 25 with severe complications, then we can start considering bariatric surgery or some invasive procedures. The goal of this evaluation of the comprehensive evaluation of our patient is to treat and prevent the complications, okay? All right, so this is a pyramid to tell us the percentage of weight loss for every intervention that we might choose, 2 to 5% just by lifestyle. But if we combine lifestyle with prescriptive nutritional intervention, 5 to 10, with pharmacotherapy, 5 to 20, with endoscopic procedures, 10 to 20, and surgery, 20 to 40. We always need to add lifestyle modification in any intervention that we're going to apply to our patients. Lifestyle is very difficult, and I agree with everything that I've been told so far in terms of how to approach a patient. The first thing we need to assess when we have a patient with obesity, with diabetes, is readiness. We need to ask our patient, or we need to assess how the patient is the patient ready to make the changes? We need to meet where they're at. If we're not there yet, we can't implement life changes yet, because there's no way patient's going to adhere to what our suggestions is. So very important, the why. I love that conference when you ask why that patient. And also important, when you have a patient that it doesn't have a BMI elevated, and ask them the trend, because you can see that patient with a BMI maybe in 20, it's not even overweight, but maybe year before had a BMI in 18, and it's trending up and it's trending up and it's trending up. But if you don't evaluate the past, you don't know where they're going to be in the future. So it's very important to ask, have you lost some weight or have you increased some weight lately? And immediately the patient, like you can ask, I know some of them, you're not clinicians, but it's very important to address the trend because you can prevent this from happening. So physical activity, great that we have people here that works in the exercise area. Physical activity not only increases the energy expenditure, but also at the same time preserve the lean body mass, the muscle. We need to preserve our muscles. All this therapy, every time you lose weight, you also are losing muscle mass. And that is a highly metabolic tissue in our body. So I don't know if you have heard that people lose weight and the metabolism gets a little bit lower, and then you eat and you increase weight all of a sudden when you stop all your medications or your regimen. Is because of that decreased metabolism, and fat could and muscle mass could play an important role in that. So we need to preserve our muscles, especially that sarcopenia from aging. The more we age, the more we lose weight, and that's a physiological situation everybody's going to encounter. But if at the top of that, you add diet, you add pharmacotherapy, you add a bariatric surgery, you need to preserve that muscle. And the best way is with weights. Lifting weight, not too much cardiovascular exercise, but weight will guarantee preserving that muscle. Nutrition is also a very good aspect. There's many diets. The only thing that works is restricted calories, 500 to 1,000 calories less than what the usual calorie intake of that patient will reduce at least 1 pound a week. So it's very simple. Just tell the patient, give me a diary of what you eat a day in a regular day. You add those calories, rest 500 calories, you can guarantee some weight. Calorie restriction, you can do intermittent fasting, keto, Mediterranean, whatever works for your patient. We need to make patients adhere to the diet. Therefore, my suggestion is always ask them, what does it work for you? Maybe you wake up and you're not hungry. So maybe you could work with intermittent fasting. Or maybe you are hungry and you want to eat several times a day. But the only thing that will guarantee losing weight is restricted calories. That's it. That's at the bottom of it. My suggestion is always include macronutrients to the diet. All your macronutrients should be those low carb diets, maybe that apply for diabetic patients, but not for everybody. Every macronutrient is important to consume. Stress, of course, stress and the why, that's where the why comes here. You need to address the stress. Diet meals can represent the increase of dopamine. Dopamine is a substance that increases pleasure. So sometimes the patient is not hungry. The patient is eating just for pure pleasure. And that's comforting. So stress could be an important factor to address. And of course, sleep. Sleep increase ghrelin. There's a lot of data out there that sleep deprivation can increase the hormone that's called the hunger hormone, which is ghrelin. Pharmacotherapy is already approved that you can start pharmacotherapy with a BMI more than 27 with any comorbidities. Of course, ACE is proposing more than 25 and the BMI above 30. These are all the medications are in the market. There's only one missing in this table, that is tirzepatide. We have phentermine. Phentermine's been long time in the market from 1997. It's the oldest one. And it's very cheap, but you need a prescription to get phentermine. The only thing about phentermine is that you can have some cardiovascular side effects like palpitation and high blood pressure. We have Orlistat. You can get this over the counter. And the Orlistat, the only thing is that can give you too much side effects because inhibit a hormone that's called lipase, an enzyme that's called lipase that inhibit absorption of fat, but that fat needs to go somewhere so you can have a lot of GI side effects. You also have the combination bupropion, naltrexone, phentermine, topiramate. The only thing is the medication interactions. And then the famous one, liraglutide, which is Saxenda, semaglutide, Wegovy, Ozempic, and tirzepatide, Zepbound, the brand name Zepbound or Mounjaro. So these are the most popular one for one reason. First, it's been proven that you're going to reduce the weight. It's not like the other ones that the reduction of weight is not that much. And for some people works and for people don't. This one, it works. It really works. The other aspect about is so important of these medications, which I love, by the way, are the cardiovascular and renal protection. So this is one of the conditions that you can add medications like this GLP-1, GIP receptor agonist when you understand first the patient. So and that's important, the previous presentation, because it's a little bit concerning that there's a portal there's no physician assessing patients, just a portal and a questionnaire and sending GLP-1, GIP receptor agonists to the front of the door of a patient without a good assessment of the patient. Remember, these medications have contraindications like thyroid cancer, pancreatitis, history of pancreatitis, etc. I'm so sorry. So the other treatment is or therapy is bariatric surgery. The most important ones are sleeve and Rook's gastric bypass. And these are the procedures. And the non-surgical procedures are just balloons, inserting devices in the gastric, the stomach to reduce the capacity of the stomach. And it gives more satiety. But at the end, this is ACE proposal to redefine obesity. And one of the reasons why this was brought up is to destigmatize the word obesity. Obesity has this word obesity, it has too much stigma in society. So what ACE wants to propose is adipose-based chronic disease, or ABCD, as a new term of obesity. So we don't focus on just the weight, and we focus more on what the body fat, abnormal body fat, will do to our health. These are some cases. I understand. I don't know how much time do I have left.
You're over. We've lost a few speakers, but so the day will be shorter, but you're a couple minutes over.
We can stop now because the rest what I have is some cases, and that's it.
Yeah, we're well over time.
Okay, so let's do this just last case and we're done. So this is a 35-year-old male that presents with weight management and have been focusing on lifestyle modification and wants to discuss some medications. So his past medical history is hypertension and dyslipidemia, taking hydrochlorothiazide and atorvastatin. He's cutting some calories. He's not eating too much sodas now and less processed food. He walks 20 minutes a day, but he's unable to engage in more activity because of fatigue. This is a very important sign, the fatigue, because remember what I told you, is not about the number in the scale. It's not only about the BMI, it's about the complications. And fatigue could be related to one complication. So the examination, he has a BMI of 28 and blood pressure a little bit elevated. The rest is normal. So what are we going to do next with this patient? Are we going to assess thyroid functions, screen for sleep apnea, referral to cardiology, or just start medication like phentermine? So in this case, we need to assess for more comorbidities of this patient. We need to first make sure and how do we stage this patient in order to do the intervention that is correct for the patient. So I have more cases, but I'm not going to be moving forward because I don't have time. If you have any question, I'm more than happy to answer them.
Thank you to Dr. Willis for presentation of a certificate and a memento.
grade-free obesity and cardiovascular problems, what you do first? Directly send him to bariatric surgery, or give the patient time and start anti-bariatric treatment for, I don't know, 3 months, 6 months, evaluate after this time,
Yeah.
or directly send to bariatric treatment?
Yeah, very important question, because that's one of the most frequent cases that we see in clinic is the cardiovascular conditions with patients with obesity. So the first thing is to stage the patient, of course. If we already know the patient has a BMI more than 25, which in that case will be more than 25, with established cardiovascular disease, that will make him in a category 3, or stage 3, right? Because the patient has, but this is based on the importance. So we first start with lifestyle. Lifestyle needs to be added in every single patient that we're treating. Then we can start with this anti-obesity medication as a second step. And if that fails, we don't have the reduction, at least 5 to 10% of the reduction of the weight, then we can start considering the surgery. Yes.
Thank you very much.